Hola, estudiante. This is Diane Wise, and we are going to talk about cancer. Actually, we're going to talk about the concept of cellular regulation, which is basically cancer and what has caused a disruption in the homeostasis of the body. The goals and objectives we have for this lesson are to define and describe the concept of cellular regulation, to understand the difference between normal cellular growth and abnormal cellular growth, notice risk factors for impaired cellular regulation, recognize signs and symptoms of impaired cellular regulation, and organize appropriate nursing and collaborative interventions for the care of clients with certain cancers. So they define and describe the concept of cellular regulation refers to all functions carried out within a cell to maintain homeostasis, including its responses to extracellular signals such as hormones, cytokines, and neurotransmitters, and the way each cell produces an intracellular response. Cellular is hard to say more than once or twice or three times. The scope of the concept goes from normal growth, normal cell growth, to dysplasia, which is abnormal but not malignant, all the way up to malignant neoplasias. Okay, let's start by reviewing normal cellular reproduction and growth. Mitosis is the action of one cell dividing into two cells. That's what all of our non-sexual cells do. When our cells regenerate, it's going to be one cell will divide into two, and there you go. Meiosis is the action, the process of which one cell divides into two half cells. And so you get a mama's one cell and a daddy's one cell. Each of those one cells will divide into two half cells. And of those, two half cells will join to create one cellular being, otherwise known as a baby in the future. So that's meiosis, that's the sex cell division. The cell cycles will vary based on the type of cell that you're talking about. Not all cells will go through cell cycling. Not all of them will regenerate themselves. For example, the heart muscle. That heart muscles develop very early in pregnancy, about 12 weeks. Once that heart muscle has been completely laid down and developed, you don't get any more cells in that. What you're born with is what you have. Because of this, because cancer requires cell division and cell cycling to exist, it is really unlikely anyone would ever get heart cancer. Now, you can't say never because there are always exceptions, but cancers of non-regenerating organs will not happen very often, if at all, because cancer loves to interfere where cells are cycling. Differentiation is a term that is basically saying that normal cells are well differentiated, they're well defined, they're very they're like round and the borders are well differentiated. I don't know how to any better explain that. I hope that makes sense. Orderly cell growth and life cycle is dependent upon a balance between proteins that promote cell division and proteins that limit cell division. The proteins that promote cell division are called cyclins, and the proteins that limit cell division are suppressor gene products. Anything that interferes with this orderly system will result in neoplasia, and this neoplasia may be benign or cancerous, malignant. So know that that balance has to exist for an orderly cell growth and life cycle. Neoplasms can be either benign, which is an excessive growth of normal cells that are not capable of metastasis, or malignant, which are abnormal cells that are capable of metastasis. The stages of development of a malignant neoplasm are initiation, promotion, progression, and then metastasis. Kind of think of it as a party that's gotten out of control, okay? First, they initiate the party. There's some people show up that you weren't sure that they even were supposed to be there, but it's okay. There's only a few of them, so you invite them in. You say, okay, whatever. We're gonna. You can stay, but just behave, right? But then you have other people outside that you don't know. They're down the street there, and they're promoting this party. You do not even know it, but they're down there. Go, hey, there's a party down in the house down there, third house down there on the left, and you don't even aware of it. But these people start showing up to your party because of the promoters. So then all of a sudden you see a progression of your party from a kind of a controlled environment where you had maybe a few strangers, but now it's starting, more and more people are coming in there, and you're feeling like this party's getting out of control and this is just not working anymore. I don't know who these people are. I want to get them out of here. But before you know it, this party not only overtakes your house, but it goes out into the streets and takes over the neighborhood, and the cops are called. Now you're in big trouble. Okay, that is basically cancer. The initiation phase is the first step. Normal cells will start losing their ability to be regulated because their genes that promote cell division are turned on excessively and they get overexpressed. And then the suppressor genes aren't working either because they're damaged. So you've got that initiation of this whole thing that's going to come down on you by overexpression and a lack of ability to suppress it. Initiation is an irreversible event. Okay. The next stage is going to be that promotion. And the promoters in the case of cancer, a couple of them would be insulin and estrogen. Those are two body proteins that can promote cancer. The progression is exactly that. The progression just continues to make more malignancy over time. And they eventually become something that will be detected by palpation. Tumors of 1 centimeter size, interestingly, will have 1 billion cancer cells in it. Woo. And the tumor, it will also at this point have to develop its own blood supply. And it does. It does a very good job of that. It just starts tentacling out and creating its own branches into the tumor. The capillaries will grow branches into the tumor, and it begins to live through that. And then they keep dividing, keep initiating cancer cells, and it'll metastasize outward into the other areas of the body. Okay. And the primary location will be what type of cancer they have, no matter where it's found in that metastatic state. So breast cancer can metastasize to the spine. So if that person has cancer in the spine, they still have breast cancer. It just now metastasized to the spine. So that primary site is what type of cancer they will have, the primary tumor. The secondary tumors are what happens in that metastasized site. Okay. There's also bloodborne metastasis, where the tumor cells are released into the blood, and it is the most common form of cancer spread. And enzymes secreted by tumor cells also make large pores in the patient's blood vessels, which allow tumor cells to enter the blood and circulate. So it's really a self-feeding system. Normal cells have a specific morphology. You can predict one's going to look like the other in that organ, okay? They have a smaller nuclear to cytoplasmic ratio. In other words, draw a circle on your paper and make a small nucleus. It's going to be a small one related to that bigger circle. Normal cells have a differentiated function. They do something. They're not just there. They have a function that helps keep us alive or perform something for us that we need. Tight adherence occurs with these cells because these normal cells make fibronectin, which is an adherence agent. So they stick together. They are non-migratory. They're not going to wander from the lung to anywhere else. They're orderly and they have well-regulated growth. Cells exist in a resting state. They just kind of hang around in there until they're needed. And how do they know they're needed? Cyclins are activated. And when cyclins are activated, they allow the cell to leave that what's called the G0 state. It's not go, it's a G0 state, and enter into the cycling phase. The cyclins then drive the cell through the different phases of the cell cycle and then divide. Proteins produced by suppressor genes control the amount of cyclins present and ensure that cell division occurs only when needed. It prevents them from getting out of control. No out of control party, because the suppressor genes are the cops saying no, go. And basically it's about a 1-to-1 ratio of cells destroyed, cells regenerate, remade. Three final characteristics of the normal cell. They have what's called contact inhibition. This stops further rounds of cell division when the dividing cell is completely surrounded and touched by other cells. Each cell divides only when some of its surface is not in direct contact with another cell. And once the cell is in direct contact on all surface areas with other cells, it no longer undergoes mitosis. In other words, once the cell is completely surrounded by other cells, it's just, okay, I quit. I'm good. I got you. I'm doing my job here. So it keeps growing until it can't space-wise, surface space-wise. Apoptosis is programmed cell death. It's normal. Normal cells do have a finite lifespan, and so that apoptosis plays a role in cancer because that does not exist in cancer. So cancer cells do not have a finite lifespan. They just keep on growing. They just stay there and just keep creating havoc. The chromosome structure of normal cells is called euploidy. That's normal. Benign versus malignant cell growth. We're going to talk about benign first. It's cellular growth, but what keeps it from being malignant? Benign growths are harmless. They do not usually require intervention. They still have a specific morphology. They have a smaller nuclear to cytoplasmic ratio, so they're not exceeding that nuclear cytoplasmic ratio. They continue to perform specific differentiated functions. They do tightly adhere to each other, and they continue to make fibronectin, which is that adherence agent. They do not migrate. They have orderly growth, and they have normal chromosome makeup. Okay? Examples of benign cell growth would be your skin tags, moles, uterine fibroids, nasal polyps. They will not cause any long-term problems. Malignant cell growth is basically everything opposite of what we just said about normal and benign. They have anaplasia going on. They no longer resemble that parent cell at all. They have a larger nuclear to cytoplasmic ratio. So look at that circle you drew on your paper and now make it huge inside that cytoplasmic circle that you drew. That's evidence of malignancy. They have no purposeful function. They have a very loose adherence because they cannot make the fibronectin. They migrate or metastasize. Their contact inhibition does not occur. They just keep moving over. Keep going. Rapid or continuous cell division occurs. They do not respond to signals for that apoptosis, so they don't have a signal to die. They have an unlimited lifespan. They're immortal, of course, until they kill the host. And they have an abnormal chromosome called aneuploidy. Grading cancer is important to understand with patients what types of cancer they have, certainly, but also what is the level of involvement. And this graph here and the one coming up on the next screen will show you exactly how they are graded. A GX, the grade cannot be determined. Okay, a G1, the tumor cells are well differentiated and closely resemble the normal cells. This grade is considered a low grade of malignant change, and you can tell because they're still well differentiated. They still look a lot like the normal cell. they're relatively slow growing. So if you have a grade 1, you're feeling like, okay, we can probably get this one, okay? A grade 2 would be tumor cells that are moderately differentiated. They still retain some of the characteristics of their normal cells, but also have more malignant characteristics than the grade 1s do. Grade 3 tumor cells are poorly differentiated, but the tissue of origin can usually be established. These cells have few normal cell characteristics. The grade 4 tumor cells are poorly differentiated and retain no normal cell characteristics. The determination of the tissue of origin is difficult and perhaps even impossible. There's TNM classification is tumor, node, and metastasis is what that stands for. The primary tumor is basically the size of the tumor. The TX primary tumor cannot be assessed. There's no you don't have evidence of it showing up. A T0, there's still no evidence of a primary tumor. A TIS, you do have carcinoma in situ, and T1, 2, 3, and 4 will give you the increasing size and or local extent of the primary tumor. Regional lymph nodes with the N with an X, regional lymph nodes cannot be assessed. And O means they were assessed but no evidence of metastasis. And 1, 2, and 3, increasing involvement of regional lymph nodes going out further from that primary site. Distant metastasis, the MX is presence of that distant metastasis cannot be assessed. We don't know. M0 means there is no distant metastasis, and M1 means there is distant metastasis. So become familiar with these stagings so that you can understand the level of treatment that each of these patients is going to need. All right, we've gone through this, so I'm going to ask you a question for you to answer. The nurse understands that normal cells and benign cells share which characteristics? Select all that apply. And I hope you have the answer right. We will check on that on Friday. If you have questions on that, you can refer back to the slide, and I'm sure you can figure that out. Consequences of malignant neoplasia. Without successful treatment, the patient will have fatigue, weight loss, pain, organ failure, and death. Fear, stress, and anxiety, of course, will result. Changes in family dynamics as the family deals with this new diagnosis, each member in his or her own way, depending on coping abilities, age of the family member, the relationship, the dynamic between the patient and the person involved. Of course, there's financial challenges. This can become quite financially devastating to families, and changes in self-image and interpersonal relationships. Fear is going to be the big one here, and it's going to infuse into all of these other things that are on this chart right here. All right, this is a way to teach you about this one. The nurse is caring for a patient who's concerned about developing cancer. The nurse recognizes that cancer occurs how frequently in people currently living in North America. So I'm going to let you take a guess, and then I'm going to tell you that the correct answer is B as in boy. 1 in 3. 1 in 3. Look around you. Look on the left, look on your right. Well, in class, look on your left, look on your right, and one of the 3 of you is going to have cancer. Yeah. This is a chart, just you don't have to memorize it, but just get an overall idea of the different types of cancers in the male and female population in the United States and Canada. Male, the prostate is the most common one, and in female, the breast cancer is. Lung and bronchus then fell. Everything else just kind of falls down from there. So just kind of get familiar with that. You're not going to have to regurgitate this back, but I think it's important to see the different types of cancers. And then the number of deaths due to the cancer, and lungs cancer is the one that's most deadly, as you can see, followed by those prostate and breast cancers. So the lung cancer it's just harder to treat than breast and prostate. What are the risk factors for impaired cellular regulation? Talking about risk factors, I think each one of us would have probably written smoking and tobacco down as the first thing that came to our mind as far as preventing cancer. It's the most obvious one, and it is responsible for about 30% of all cancers. Yeah, quit smoke, gang. Poor nutrition will also increase the risk of cancer. Eating red meats, a lot of red meat, having low fiber diets will put a person at increased risk. So nutrition is an important area to investigate with our patients. Excessive weight, having the increased adipose tissue, that adipose tissue picks up and holds estrogens that can be cancer promoters. Sedentary lifestyle, just not being active and not letting your blood get flowing around and giving your healthy cells oxygenation. Just encourage some type of activity every day. Exposure to environmental carcinogens such as sunlight, sun worshipers, pollutants in the air, soil, water, or food, or medical treatments such as medications or radiation. Genetics plays a role in some cancers and infectious agents. Recognizing when an individual has signs of impaired cellular regulation is important in helping to do early detection, because the early detection is one of the two best methods to survive cancer. Number one, let's prevent it in the first place by minimizing risk factors, and number two, let's do secondary prevention, which is to catch it early. Get your screening done, get everything done that needs to be done to evaluate your risk that where you're at. Common diagnostic tests that can be done are radiographic tests such as X-rays, MRIs, CTs, radioisotope scans, ultrasound, and diagnostic mammography. Direct visualization through colonoscopies and endoscopies, just actually looking for colon polyps, which can be precancerous cells. Laboratory tests, CBCs, chemistry panels, genetic or tumor marker tests. Pathology, examination of cells and tissues for a diagnosis of the malignancy, the tissue type, and the grade. As we go through some of the systems that we're going to dig into deeper later on, we're not doing that in this particular set of PowerPoints, but we're going to just kind of review what types of symptoms you would ask for with your patient to know, to do some verbal screening of symptomatology. First, we're going to talk about benign prostatic hyperplasia and or prostate cancer. Their symptoms will be very, very similar. It's going to take a biopsy to determine if it's benign or cancer. So hesitancy of urination would be a potential symptom because the prostate's gotten enlarged and prevents the urine from being able to easily exit the bladder. Change in the size of the urine stream for the same reason. If there's hypertrophy, the prostate's could cause that urine stream to become less strong and less wide, so to say. Pain in the back or the legs is another potential symptom of that. And then history of urinary tract infections. It's really unusual for men to get urinary tract infections because the length of their urethra is so much longer, and so it's farther for bacteria to get up into the urinary tract and the bladder. But so if they have a urinary tract infection issue, that would be one thing to make sure we're not dealing with stasis of urine because of the prostatic hypertrophy. Bladder cancer, we would ask the patient again about pain on urination, blood in the urine, is it cloudy urine, is there increased frequency or urgency? Lung cancer, let's look at the skin and mucous membranes for color. Do they have good capillary refill? Are they perfusing well? How many words can the patient say between breaths? It's an interesting one. Ask the patient about coughing, hoarseness of the voice, smoking history, Did they ever smoke and how long ago did they quit? How long did they smoke? Exposure to inhalation irritants, exposure to asbestos. That was used to be quite the deal for many decades ago. Fortunately, we're getting that stuff out of our buildings. Slow but sure. Shortness of breath, of course, activity tolerance or intolerance, frothy or bloody sputum, pain in the arms or chest, or difficulty swallowing. Colorectal cancer. Has the patient's bowel habits changed over the past year? Are they different in consistency, frequency, or color? Is there any obvious blood in the stool? We would take at least one stool specimen for occult blood during the patient's hospitalization. And we encourage patients to have baseline colonoscopies if they have any of these just mentioned symptoms. Encourage the patient to reduce dietary intake of animal fats, the red meat and smoked meats. Do a history on that. Take a history of, what do they eat, and encourage them to increase the bran, vegetables, and fruit. Skin cancer, we do a good thorough exam of the skin areas for moles or warts. Knowing the age of your patient will make a difference, because as you get older, people get what we call brown spots, old age spots. They're not cancerous, they're just ugly and annoying, speaking personally. Sorry, that was diversion. Ask the patient about changes in their moles. Have they noticed any difference in the color, in the edges, and in sensation? And realize that, again, if cancer is happening in the moles, those edges are not going to be nicely round. They're going to start to get raggedy looking. Okay, they're not going to have a perfect circle to them. Assess for lesions. Anything that's abnormal, whether it be a skin tag or there are different types of lesions that happen when we get older as well, and just be very thorough on that. And skin tone and color. I would also want to ask them about their exposure to sunlight throughout their life. Were they a sun worshiper? Do they do tanning beds a lot? Get some history on that. In regards to leukemia, observe the skin for color, for any petechiae or ecchymosis, signs of heavier bleeding under the skin. Ask the patient about fatigue, bruising, bleeding tendencies, history of infections and illnesses, night sweats, unexplained fevers. Do they seem to have a compromised immune system that could indicate the problem with leukemia? The primary cancer prevention is tobacco use is a causative factor in 30% of all cancers. Inform all patients who smoke that smoking increases the risk for development of many cancer types, and assist anyone interested in smoking cessation to find an appropriate smoking cessation program. With diet, teach to avoid excessive intake of animal fat, nitrites, and red meat, and limit alcohol consumption. Dietary recommendations include eating more bran, cruciferous vegetables, and foods high in vitamin A and vitamin C. Examples of these would be apricots, carrots, leafy green and yellow vegetables, fresh fruits, and citrus. Primary prevention includes teaching patients to use sunscreen and to wear protective clothing during sun exposure. I think tanning beds should just be outlawed, personally. Of course, I think cigarettes should be outlawed, personally, but that's just me. We don't need those risk factors in our lives. Vaccination is a new method of primary cancer prevention. It's still in infancy stages. Gardasil is a vaccine for preventing infection from several forms of the human papillomavirus. Condylomata is another, genital warts on the cervix. It is hoped that more vaccines will be developed for prevention of other types of cancers. Regarding Gardasil, I'm not going to make any political comment on it, but I would encourage anyone to do research before getting the vaccine. It's still in early phases, and I'm personally not real comfortable with it, but they're working on it. Secondary prevention is that which helps catch this stuff as early as possible. Encourage patients to participate in the recommended cancer screening activities for their age group and cancer risk category. which we'll see in another slide here. Obtain a detailed family history of at least going back at least 3 generations, and use this information to create a pedigree to assess the patient's risk for familial or inherited cancers. Assess the patient's knowledge about causes of cancer and his or her screening or prevention practices. Start with what they know. We need to first understand where the patient is at before we can progress into the teaching zone. So find out what they know, understand, or currently believe. Assist patients who fear a cancer diagnosis to understand that finding it at an early stage increases the chances for cure. Ask all patients about their exposures to the environmental agents that are known or suspected to increase the risk for cancer. This is the schedule for secondary prevention or diagnostic procedures that is recommended by the American Cancer Society. They recommend a yearly mammogram for women older than 40 years. Additionally, those women who are at risk for an increased risk for breast cancer due to family history will start having their mammograms earlier, like 35 years of age. In addition to that, yearly clinical breast exams for women older than 40 years, every 3 years for women ages 20 to 39 years. We also will be teaching these women how to do their monthly self-breast exams. It's not always up to the provider in the office and the x-ray machine. Let's teach these women how to, and men can get breast cancer as well. So check the breasts, have them check their breasts every month after their period is over for breast masses, and it's done after the period is over, because that's when the breasts are the softest and least lumpy. For someone who is post-menopause and no longer has a period, we tell them to do their breast exam on the first of the month, every month. And interestingly, most breast cancers are found by the patient doing her self-breast exam. They're not found by the provider. They're found by the patient. So it's very important that that is included in the teaching. Colonoscopy should start at age 50 years and then every 10 years after that. A yearly fecal occult blood for adults of all ages, simple enough to do. It's gotten even easier throughout the years. And a digital rectal exam for men older than 50 years to check that prostate. It's important to teach our clients about the 7 warning signs of cancer. And it's a mnemonic of caution. C is changes in bowel or bladder habits, a sore that does not heal, unusual bleeding or discharge, thickening or lump in the breast or elsewhere, indigestion or difficulty swallowing, an obvious change in a wart or mole, and a nagging cough or hoarseness. Go through this list again in your mind and determine what cancer this would be referring to and be concerned about. And that's it for this set of PowerPoints. We're gonna, you can look forward to the individual detailed ones on the rest of our exemplars, but that's it for tonight.